causes positive feedback when an estrogen stimulate the pituitary again causes LH surge. Because of this LH surge, there is ovulation. Ovum will rupture and they will release the ovum into the peritoneal cavity. That is called ovulation. So after the ovulation, this LH further will act on the remaining cells and they convert into the remaining cells to the corpus luteum. So LH act on the corpus luteum and continuously produce progesterone. Now the estrogen is over. Now progesterone comes to the picture. Because of the progesterone, this endometrium will go into what is called the secretory endometrium. No more proliferation. It's MCQ. Because of the progesterone, no more proliferation. It goes into the secretory phase. So you all know for the endometrial cancer, you need estrogen. Estrogen causes proliferation. If this proliferation continues, end result is endometrial hyperplasia and cancer. So as a treatment option, can you all remember in endometrial cancer stage 3 and 4, progesterone is a treatment option. Why? Progesterone stops the cellular proliferation and convert it to a secretory endometrium. Okay, right. Now what happens is there is dominant progesterone, so endometrium will go into a well-nourished secretory endometrium. What happens? Now because of the corpus luteal production of progesterone level is now rising. When the estrogen level is rising, they will further stimulate the pituitary and ovary. Like a politician, when they earn money, they want more money, positive feedback manner. But progesterone is not like that. Okay, what does progesterone do? When the progesterone levels are rising, they go and tell the pituitary, look, I have enough progesterone, stop the production. So what they do is they go and cause what's called negative feedback inhibition. As a result, LH level drops. When the LH level drops, there is no stimulation to the corpus luteum atrophy, no progesterone. When the progesterone level drops, what happens is endometrium cannot be maintained, it sheds off. That is called the menstruation. For the menstruation to happen, you need withdrawal of progesterone. So this is the same thing that we used in, some of the questions are based on what is called progesterone challenge test. Have you all seen those questions? We discussed recently also in mock papers, right? Progesterone challenge test. What is progesterone challenge test? Because you all know, some of the women, especially women with polycystic ovarian syndrome, there is no ovulation. So what happened because of the FSA, follicles are grouping. There is enormous production of estrogen. Estrogen stimulates the proliferate and proliferate. Since there is no ovulation, no progesterone comes. What happens? Endometrium will keep on growing. So for those women, if the menstrual cycle is going more than 3 months, it's a risk factor for endometrial cancer. So you have to stop that cycle, or you have to induce bleeding. How you can induce bleeding? You give progesterone for a short period. Then the endometrial proliferation stops and it will go into secretory endometrium. Then suddenly you stop progesterone. Once you stop progesterone, because of the withdrawal, you will get the withdrawal. So this is called progesterone challenge test, one of the questions. So a woman who is not having menstruation, you can induce the bleeding by giving progesterone. But remember, the same question asks, for the progesterone to act, there should be prior estrogen activity. If the estrogen was not there before, you can't induce bleeding here. So typically, patients with this patient, very important patient, polycystic ovarian syndrome patient, they have enough estrogen. They have the endometrial proliferation. So if you want to have the bleeding, you give a bit of progesterone and withdraw it. Then you will get the bleeding. Same question can be asked next time, this time. How? Suppose a patient who has reached menopause, you know, when a patient reaches menopause, there is no bleeding. By giving progesterone challenge test, can you withdraw? Can you have the bleeding? Have you got my question? Charita, have you got my question, Arun? Yes. The question is, now you all know, if someone is not having bleeding, okay, not having bleeding, provided the ovaries are working, how you are not having bleeding, typically in an ovulation, you can have the bleeding. You can induce the bleeding by giving progesterone. That is called positive progesterone challenge test. I'm asking Darwin, if a woman reached menopause, now ovaries are not functioning. Okay, so suppose a woman comes at the age of 55 years, tell you, doctor, I don't have bleeding over last 2 years, but I want to have bleeding. Can you induce bleeding by giving progesterone? Pulasti, can you do that? And Makyagana, can you do that? No. Why? Because in menopausal stage, ovaries are not working the room. So no estrogen. So there is no endometrial proliferation. So even though you give progesterone, you can't induce bleeding. Okay, yes, Dinuko, that is the answer, right? So please remember, anyone who is not having bleeding by giving progesterone, you can't induce bleeding. For someone to have positive progesterone challenge test, there should be estrogen prior activity. Prior estrogen activity. This is a question being asked and can be asked also. Have you got the practical point of this estrogen progesterone business, Taru? Yes, clear, right? Any problems? If you all have any problems, please let me know. Okay, this is the final chance for you all to recap your theory knowledge. Okay. Okay, King, are you with me? Good. Right. All right. Okay. So now, have you all understood up to this point, Taru? Yes. Right. Now, at the beginning also, I told you all the ovary is called gonad. What? Gonad. These hormones which act on the ovary are called gonadotropins. Okay. So, because depending on that, there are various conditions where you can give different the names, same condition but different names with funny names like this. Now, suppose when a woman, say for example, when a woman reached menopause, what do you all mean by reaching menopause, Daru? A woman reaching menopause means her ovaries stop their functions. Not 100%, but 95, 96%, their function goes down. What function being ovulation and the estrogen production goes down. That is called menopause. So when the ovaries are not producing enough estrogen and progesterone, especially the estrogen, what does the pituitary and the higher centers do? Especially the pituitary. They give more stimulation, more force. Okay. So what happens is, if there is less production of estrogen and progesterone from the ovaries, what happens is your FSH and LH levels are rising. That's why when a woman reaches menopause, FSH level is very high. That diagnoses the condition of menopausal state. Okay, so when now ovary also an endocrine organ, it produces estrogen and progesterone and a lot of other hormones also. What are the other hormones that are produced by the ovary? Any other hormones? Inhibin, activin, can you all remember inhibin? Yes, right? So just give me 1 second. Right? So inhibin, activin, mullerian inhibin substance like various other hormones are also produced by the ovary. It's not only estrogen and progesterone. So Darwani, when the endocrine organ has a less capability or less production, that is called hypo, like hypothyroidism, like the same way hypo. Hypo means less production. So when the gonad is less producing, that is called hypogonadism. Hypogonadism. Hypogonadism, like hypothyroidism, hypopituitarism, the same way, hypogonadism. Everybody listen this one. Okay, we discussed a question last week also, I think, yes. So hypogonadism means ovaries are not functioning. So when ovaries are not functioning, you will get excessive production of FSH and LH. That is called, this is hypogonadism, this is hypergonadotropins. Gonadotropins are high, however, gonad is hypo, less producing. This is called hypergonadotrophic hypogonadism. Hypergonadotrophic hypogonadism. So in the exam, if you see this term, what does that mean? Hypergonadotrophic hypogonadism. What does that mean? HP, what does that mean? Hypergonadotrophic hypergonadism. Hypogonadism means the ovary is not functioning well. Hypergonadotrophic means you have no FSH channels. What is the typical example? What is the typical example, Samira? What is the typical example for that? Anyone? What is the typical example for that? Menopause. When the woman reaches menopause, ovaries are hypogonadotrophic. Hypogonadism, but FSH and LH levels are very high. Hypergonadotrophic hypogonadism. Typical example is menopause, either premature menopause or normal menopause, whatever is the condition. Gonads are not working, so FSH and LH levels are high. So in the exam, if you see a term, hypergonadotrophic hypogonadism, example is menopause. Okay, right. So you will get another hypogonadism. Like hypogonadism means ovaries are not functioning. Suppose your hypothalamus is not working. Hypothalamus is the top person. Suppose hypothalamus is not working, or the pituitary is not working. As a result, you will not get adequate FSH and LH. As a result, ovary may not be working. So ultimately, that is also hypogonadism. But gonadotropins are less. That is called hypogonadotrophic hypogonadism. Greek hypogonadotrophic hypogonadism. Again, hypogonadism. Hypogonadism means ovaries are not functioning because you have less gonadotropin hormones. That is called hypogonadotrophic hypogonadism. Any examples? Darwani? Yes, any disease affecting your hypothalamus or the pituitary. Like, if you start with the hypothalamus, Kallman syndrome, very good. Stress, weight loss, weight gain, infections. When you come to the pituitary, Sheehan syndrome, very good. Sheehan syndrome. Okay, or pituitary tumors, something like that. Any higher center problems causes hypogonadotrophic hypogonadism. So there is no problem with the ovary. Ovary cannot produce hormones because there is no stimulation. See the difference, Daru? So far I introduced you all two hypogonadisms. Two reasons why the ovary is not functioning. One reason is there is a problem with the ovary. Ovary stop their functions. So in that case, you will get excessive gonadotropin. That is called hypergonadotrophic hypogonadism. Typical example is menopause. On the other hand, Daru, you will get less ovarian function because of the higher center problems. That is called hypogonadotrophic hypogonadism. Okay, right? When it comes to the ovary, Daru, one of the common diseases is called polycystic ovarian syndrome. You all know about the condition of polycystic ovarian syndrome. Polycystic ovarian syndrome, even though they produce hormones, estrogen and progesterone, there is no ovulation. So mainly they are anovulatory. There is no ovulation. Okay. So in that condition, since there is no ovulation, however, their FSH and LH levels are high. So that is called hypergonadotrophic anovulation. There is no ovulation. However, FSH and LH levels, especially LH levels, are very high. Hypergonadotrophic anovulation. Typical example is polycystic ovarian syndrome. Typical example is polycystic ovarian syndrome because in that case, ovaries are functioning, estrogen and progesterone is produced, mainly estrogen is produced from the progesterone, estrogen is produced, and there is no ovulation and ovulation. Polycystic ovarian. However, FSH and LH levels are high. So hypergonadotrophic anovulation example is polycystic ovarian. So please remember about these terminologies. The same conditions that causes menstrual problem, but you can categorize, right? Gonad means the ovary, the gonadotrophins are FSH and LH. If the ovary is not functioning well, hypogonadism. If the FSH and LH levels are high, that is called hypertrophic hypogonadism, like ovarian failure, menopause. Or if the FSH and LH levels are low, that is called hypogonadotrophic hypogonadism. Differently, when it comes to polycystic ovarian syndrome, you can say there is an ovulation and FSH and LH levels are high, so that is called hypergonadotrophic anovulation. In polycystic syndrome, that or polycystic ovarian syndrome, they have enormous amount of estrogen. There is no hypogonadism. There is enormous amount of estrogen. Why? In polycystic ovarian syndrome, you have tiny follicles everywhere. So they produce some amount of estrogen. So ultimately, the estrogen amount on them is very high. That's why they get continuous proliferation of the endometrium. That's why they are predisposed to endometrial hyperplasia and endometrial cancer, polycystic ovarian syndrome. So people with polycystic ovarian syndrome, there is no hypogonadism. They produce excessive estrogen actually, but anovulation. So that is called hypergonadotrophic anovulation. Is that clear, Darwani? Can you all hear me? Pulasti, can you hear me? Yes? Good. Okay, right. Good. Okay, Takshila, is that clear? Good, right. All right, Daruni. Now we will discuss a little bit about how to manage or how to identify or how to analyze a patient who is coming with amenorrhea. What is amenorrhea? No menstruation. What is primary amenorrhea, Kikini? No menstruation at all. She haven't experienced the menstruation in her life so far. Primary amenorrhea. Secondary amenorrhea means the what? A woman who had previously had regular cycles, now not having menstruation for last 6 months. Like that. Okay? Suppose commonly they will get your patients like this. Patient coming with primary amenorrhea. Suppose primary amenorrhea. Okay? Primary amenorrhea. And they will use some other additional points and ask what may be the possible reason. So, if a girl comes with primary amenorrhea, no menstruation at all, where can be the problem? Because you know, if there's a problem with the hypothalamus, they can be primary amenorrhea. If there's a problem with the pituitary, they can be primary. Ovarian problem, primary amenorrhea can be primary. Or if there is anatomical problem, absent uterus, absent endometrium, transverse vaginal septum, imperforated anus, imperforated hymen. Okay, anything can cause absence menstruation. So thousands of causes, Tarshana. Then how you can point out what may be the possible reason or where is the possible problem? To identify that, if a patient comes in primary amenorrhea, the salient feature or the characteristic feature is see whether patient is having secondary sexual characteristics there or secondary sexual characteristics are not there. What are the secondary sexual characteristics? Breast development, axillary hair, pubic hair, right? Those are the secondary sexual characteristics of a female. Okay, see whether those features are there. For a woman to get these secondary sexual characteristics, the breast development, the hair development and all, what hormones are necessary? Do they need hormones? Yes, definitely. These are hormonally controlled the features. So what hormones do they need? For the breast development, mainly estrogen. You need estrogen. From where you get the estrogen? From the ovary. That means ovary should be functioning. For a woman to get this axillary and pubic hair, what hormones they need? They need androgens. Again, from where you get the androgens? Again, from the ovaries. Ovaries are capable of producing androgens as well. So estrogen is produced, the testosterone and the other, the androgens are also produced. So basically, right, to be simple, if a girl is having secondary sexual characteristics, means that when she is having a functioning ovary. That is the conclusion that you can come. Functioning ovary. Not only functioning ovary, the hypothalamus pituitary, that axis, HPO axis, should be functioning. So, if a girl is having primary amenorrhea and secondary sexual characteristics, means that you can think HPO axis should be okay. HPO axis should be okay. So, where can be the problem now? If the axis, hormonal axis is normal, why she is not having menstruation? Two reasons. One reason is there may be a problem with the anatomical pathway. Either uterus may be absent, or there is transverse vaginal septum, or imperforated hymen. Any problem here, anatomical problems. What else can it be? Secondary sexual characteristic there, but no menstruation. What is the other possibility? What is the other possibility? Anyone? What is the other possibility? Upamalika, what is the other possibility? No.
So anatomical,
yes, we talk anatomical possible, yes. If the secondary sexual characteristics are there, but no menstruation, can be anatomical. Because you know that ovaries are functioning. So that means this axis is okay. So problem may be there in the anatomical pathway. Where else can be the problem? No, Sheehan syndrome here. If there's Sheehan syndrome, you won't get secondary sexual characteristics. And the Sheehan syndrome
So
does
premature menopause?
Huh?
Premature menopause?
Not really. If premature menopause, there is no ovarian function. Okay, so in this condition, ovaries are functioning. The hormonal pathway is normal. However, no menstruation. Suppose anatomy also normal. Other possibility is constitutionally delayed menarche. Simple. Constitutionally delayed menarche. Androgen sensitive syndrome, they don't have ovaries. Stick to your basics, Darwin. Don't forget about those things, right? So be simple. Girl is coming, doctor, no menstruation. Right? So then, when you have a look, right, this girl is not too bad. All the secondary sexual characteristics are there. So you think like, okay, the HPO axis must be working. So where should be the problem? She might not be having a uterus, anatomical pathway problem. Or else, ask from the mother, Amma Vaisaki and the locula make me. Amma Kina my doctor locula make me. Then you know this is constitutionally delayed menarche. That means there is no other problem. However, the GnRH pulses to start, it takes some delay. There's some delay for the GnRH pulses to start. Okay, Nusrat? Right? So shall we all of us take a deep breath? I know that you guys had some classes before. You are studying these days, studying very hard and very tired these days. But take the maximum out of this. Okay, Anisha, right? So take the maximum of it, right? And try to recap because if you start studying alone, say for example, if you take the menstrual cycle and these problems, if you start studying, it will take at least 4 or 5 hours for you all to complete that session. But with me, it will be easy for you all to recap. Okay, right. So is that clear up to this point, Darul? So what I was talking, right? If a girl comes with primary amenorrhea, okay, see whether she's having secondary sexual characteristic, then your business is easy. That means you can assume her HPO axis is normal, then there should be a problem with the anatomical pathway. Okay, and or else there can be constitutional delayed menarche. What is constitutional delayed menarche, Praveen? Constitutional delayed menarche means that anatomically she is normal, hormonally she is normal. However, this menstrual cycle to begin with, there is some delay. Okay, that is called constitutional delayed menarche. There is no other problem. So if you think this is anatomical problem, what you can do a scan and see whether the uterus is there or not. Very simple. And in the history, if they say there is cyclical low abdominal pain, secondary sexual characteristics are there, and cyclical low abdominal pain. Where's the problem, Charita? Now it's very easy. The problem should be either transverse vaginal septum or imperforated hymen. Outflow tract problem. Yes, exactly. Outflow tract. Because she's having bleeding, but the blood cannot come out. Okay, Ashari? Right? So that one is very easy. If a woman comes with primary amenorrhea, see whether the secondary sexual characteristics are there. If they are there, then you can exclude hypothalamic problems, pituitary problems, ovarian problems. Not 100%, but to a great extent, you can exclude. So you are remaining with either anatomical problems or constitutional delayed menarche. Okay, right? Right. Then, suppose on the other hand, a girl comes with primary amenorrhea. When you have a look, she's just childish, right? No breast development, right? No breast development, no acceleration, no pubic hair, nothing. She's just like a child. Okay? Then where can be the problem? No secondary sexual characteristic means her ovaries are not functioning yet, or not functioning at all. We don't know. That means there can be problem with the hypothalamus, there can be problem with the pituitary, there can be problem with the ovary. Anywhere we don't know. Okay, right? So those possibilities are there. And not only that, she may be having anatomical problems also, we don't know. So if you get a lady or a girl with primary amenorrhea and no secondary sexual characteristic, you have to think systematically. Any hypothalamic problem like the the Pohlmann syndrome or something like that. They come to the pituitary, any pituitary tumors and all those problems. Comes to ovary, premature ovarian failure, like Turner syndrome or something like that. Okay, then see whether the anatomy is normal, like Mullerian agenesis, transverse vaginal septum, like all these things you have to think. But if there are no secondary sexual characteristics, that means most likely she is having a problem with the hormonal pathway. Okay, that's how you sort out the problem of amenorrhea. Is that clear, Darwani? If you get a question in your exam, right, regarding primary amenorrhea, right, can you all answer? Can you all, analyze the question in that way? Okay, right, good. Good. Right. So now, after that basic stuff, now I'm going to discuss with you all regarding the common menstrual problems and their management. Okay, Darwani? Right. So come to the first one, most commonly, menorrhagia. Menorrhagia. Give me another term for menorrhagia, newer term. Heavy menstrual bleeding. Heavy menstrual bleeding. Remember, in the exam, it might appear as menorrhagia or it might appear as heavy menstrual bleeding. What do you mean by heavy menstrual bleeding? She's having regular cycles. Regular cycles. However, each bleeding episode is heavy. She's passing bloods. She has to use 5, 6, 7 the sanitary pads per day. She's having features of anemia, heavy bleeding. Okay, cycles are regular. She's getting the cycles quite regularly. However, each bleeding episode is heavy. What are the causes for menorrhagia? What are the causes for menorrhagia? What are the causes for menorrhagia, Darwani? Yes, don't say fibroid. What fibroids? Charita, what fibroids? Does all fibroids causes menorrhagia? No. Either submucosal or intramural fibroids. Only these fibroids can cause menorrhagia. Either submucosal or intramural fibroids. What else, Darwani?
Adenomyosis.
Adenomyosis, yes, very good. Adenomyosis. Endometriosis. What else? Endometrial polyps.
Polyp.
Yes, good. Polyps. What else? What else? What else? Any bleeding
Coagulopathy.
disorders? Bleeding disorders like von Willebrand disease. Bleeding disorders. Yes, PID. PID. Bleeding disorders. And if you can't find a reason, then you can say dysfunctional uterine DUB. So all, yes, those are the possibilities. Okay, if a woman is having menorrhagia, these are the possibilities that you have to think. Maybe a polyp, maybe fibroids, maybe adenomyosis, endometriosis, PID, bleeding disorders, and dysfunctional uterine. Suppose if a woman is having bleeding plus severe pain with menstruation, dysmenorrhea, unbearable pain with menstruation, then what are your possibilities? Then your possibilities are: does polyps comes? Does polyps causes pain? No, unlikely. Extremely rare. Does fibroids causes? Dysmenorrhea? Usually not. Usually not. Extremely rarely, submucosal fibroids can cause some dysmenorrhea, but generally speaking, fibroids does not cause dysmenorrhea. So no fibroids, no polyps. What about adenomyosis? Yes, typically
Yes.
they cause endometriosis. Yes. PID. Yes.
Yes.
Yes, very good. And bleeding disorders and dysfunctional uterine bleeding also will not cause dysmenorrhea. So, if a girl or if a lady, if a woman is having menorrhagia only, you have to think a lot. Maybe a polyp, maybe adenomyosis, fibroids, endometriosis, PID, bleeding problems, dysfunctional uterine bleeding. If a woman is having bleeding plus pain, then you have to think about only three conditions: adenomyosis, endometriosis, PID. Okay. What is the characteristic feature of adenomyosis? They give you adenomyosis that you won't see in young people. That is perimenopausal. Usually after 35-40 years, you will get this condition. Perimenopausal, not in a young patient. So see the age of the patient. If the patient is young, it's likely endometriosis or PID. If patient is perimenopausal, like ERPM students, closer to menopause, then you have to think about adenomyosis. What is the examination finding? Uniformly enlarged or symmetrical or uniformly enlarged tender uterus. Those are the characteristic features of adenomyosis. Uniformly enlarged tender uterus. If a 45 years old lady coming with menorrhagia and dysmenorrhea, and the examination revealed uniformly enlarged tender uterus, that is nothing else, that is adenomyosis. Okay. How you can confirm your diagnosis? How you can confirm your diagnosis? By ultrasound scan. Ultrasound scan will give the features suggestive of adenomyosis, but 100% confirmation comes with the histology. So the diagnosis, for the diagnosis purpose, you use the ultrasound scan, and the ultimate diagnosis comes with the histology after the hysterectomy. So uniformly enlarged tender uterus characterize your fibroids. Adenomyosis. What about endometriosis? Do they cause menorrhagia? Right. So
Yes.
yes, they causes menorrhagia. Do they causes dysmenorrhea? Yes. What age that is common? You can see any woman who is menstruating, you can have endometriosis, even perimenopausally. However, they are more common among reproductive age. That means below 40 years, that is more common. Then age-wise, you can differentiate adenomyosis and endometriosis. How else you can differentiate? How else you can differentiate? How else you can differentiate? Adenomyosis is the one which causes enlarged tender uterus. Endometriosis will not cause enlargement of the uterus. Yes, Pramodi. Adenomyosis will cause enlargement of the uterus and the tender uterus, whereas endometriosis not. What is the other thing, Anisha? What is the other thing, Daru? In adenomyosis,
Multipara and nulliparous?
not really. Anything stronger than that? Adenomyosis, Daru, the problem is within the uterus. That's why it's enlarged uterus. That's why uterus is tender. Whereas endometriosis is outside. So endometriosis, when you examine the adnexia, either side of the uterus is tender adnexia. Yes, adnexia is tender. Endometriosis, whereas adenomyosis, adnexia is not tender. Okay, write it down, right? So endometriosis and adenomyosis is similar kind of conditions. How to differentiate? Age-wise, you can differentiate. Adenomyosis, you get the symmetrically enlarged uterus, whereas endometriosis not normal size uterus. Adenomyosis, adnexia are normal, but endometriosis, adnexia are tender. Okay. Come to PID, pelvic inflammatory disease. How to differentiate PID from endometriosis and adenomyosis? Age-wise, can you differentiate? Difficult. Even a young person can get the STDs. Even elderly people, elderly in the sense,
Presence of a
perimenopausal.
discharge.
Yes, one of the characteristics is discharge. If there is a purulent or a pathological discharge, that is highly suggestive of PID discharge. Most of the patients with PID, they won't get fever. Most, unless there is an abscess formation or something, right? Most of the patients with chlamydia, gonorrhea, those are the two common infections. Now they won't get fever. Okay, so one of the characteristic feature to differentiate from adenomyosis and endometriosis, they causes abnormal or a pathological discharge, whereas two other conditions will not cause. Can PID enlarge the uterus? No. Can PID cause tender uterus? Yes, because of the infection, there can be some tenderness of the uterus as well as the adnexia are tender. Definitely the tubes, adnexia are tender in PID, like endometriosis. Adnexia are tender. So please remember about those things. What is the management for PID? What is the management for PID? Ashari, what is the management for PID? Infection, Daru. Management for PID is antibiotics.
Antibiotics.
Yes, you have to give antibiotics at least for 10-14 days. Antibiotics should be given. If the patient is not responding to antibiotics, suppose patient is and all the features of PID, you treat with antibiotics, patient is not recovering or not responding. What is the next step?
So vaginal is that called?
Vaginal what, Daru? Antibiotics.
Vaginal is supposed.
Vaginal what, follow? I can't hear you.
what is that?
Something vaginal.
No,
Okay.
vaginal, we have to put some, insert the, insert some
Get
antibiotics.
a vaginal swab and do an ABST.
Definitely, Daru, if you suspect pelvic inflammatory disease, you have to take a sub and you have to start antibiotics afterwards. I'm telling you, suppose the sub, most of the cases, because GPs are half treated these patients. So when you do the subculture may be negative, but still patient is having PID. Strongly suspected PID, culture negative. You treat with antibiotics, not responding. What is the next step? Yes, Supamalika. Next step is, if PID is not responding to usual antibiotics, next step is laparoscopy. Laparoscopy. Why laparoscopy? Because laparoscopically you can complete your diagnosis, you can confirm your diagnosis, that is diagnostic, as well as if there are adhesions, if there are pus collections, you can drain them. So please remember, PID, you treat with antibiotics after the culture and all. You treat with antibiotics, not responding, next step is laparoscopy. Okay. The same thing applies if a patient comes with chronic pelvic pain. That means there is pelvic pain going on for 6 months or more. Chronic pelvic pain. You treat with antibiotics for a possible pelvic inflammatory disease. There is no definitive evidence of PID, but patient is having chronic pain. You treat with antibiotic. If not responding, next step is laparoscopy. So in the patient, if they ask what is the next step after antibiotics is laparoscopy. Either chronic pelvic pain or PID, if you suspect PID. Okay, clear, right? Suppose your diagnosis is either adenomyosis or endometriosis. How will you treat the patient? When it comes to adenomyosis and endometriosis, and fibroids also the same, right? You have two management options, surgical and medical. Adenomyosis and endometriosis, and also the fibroids. For all three conditions, adeno, endometriosis, and fibroids. They all response to estrogen and progesterone. You get the estrogen and progesterone from the ovary because of the menstrual cycle. So if you can stop the ovarian function temporarily or permanently, whatever the way, if you can stop the ovarian function, patient will not produce estrogen. So you can treat all these conditions. How you can stop the menstrual cycle, Daru? You can do various drugs, you can do combined oral contraceptive pills, you can give danazol. Okay, so you can use DMPA. Right? You can use DMPA and adenomyosis and endometriosis, and also for fibroids, you can do Mirena. If the cavity is not disturbed, you can put a Mirena. You can put these Meber drugs like Ulipristal. Can you remember? Progesterone receptor antagonist, right? So Ulipristal, or ultimately GnRH analogs. So anything can be given if you have adenomyosis, if you have endometriosis, if you have fibroids, symptomatic fibroids. Medical management options are same. Surgery, what you can do? Adenomyosis. Adenomyosis, only surgical management is hysterectomy.
Hysterectomy.
Hysterectomy, yes. You must remove the uterus. Remember, if a patient is having adenomyosis, usually they are, even though you start these treatments, they are usually poorly responding. So best management is hysterectomy. However, Mirena and hysterectomy are equally effective for adenomyosis. So in your SPA, if the picture is clearly adenomyotic, if there is no other reason for you to go for a hysterectomy, Mirena is a good option, because this is a major surgery, so a lot of surgical morbidity is there. However, Mirena is much more safer than a major surgery. So if a patient is having adenomyosis, Usually these drug regimes are not helpful. However, Mirena is highly helpful. So the first line is Mirena. Next step is hysterectomy. That's for the adenomyosis. For the endometriosis, Darwani. For endometriosis, what are the surgical management options? Endometriosis, you have a lot of adhesions, isn't it? So you can do laparoscopically adhesiolysis. Adhesiolysis. If there are chocolate cysts, you can do cystectomies. Cystectomies. Adhesiolysis, cystectomies. If a woman has completed her family, what you have to do, you must remove bilateral ovaries. BSO, bilateral ovaries. Bilateral salpingo-oophorectomy. So normally, when you remove the ovaries, there is no point of keeping the uterus there. So what you do is THBSO. This is the definitive treatment for endometriosis. Okay. So normally, adenomyotic patients, there is no problem with the fertility in the sense because the disease appears after, after 35, 40s. By that time, they have either 1 or 2 kids, family completed. So the fertility issues and the management problem comes with the endometriosis. So how you decide whether you need a surgical management or medical management in endometriosis depends on fertility issues. If a patient is young, or if she is subfertile, or if she wants to conceive, or any fertility issue. If a woman is having any fertility desire or any fertility wish, then medical management you can't apply. Why? If you do OCP, you can't become pregnant. If you do DMPA, no pregnancy. That is all same. GnRH same. Mirena same. Okay. So all medical management options are out if the problem is fertility. So what are the management options then? Is that clear, Daru? Is that clear? Yes. Are you all with me up to this point? Shall we take a deep breath? Nokia D and I don't know the name, sorry. Right? So are you all okay now? Some of the boys and girls, their appearance also now changed because of I think long waiting for the exam. They have put on weight and all. All right. Girls and then put device looks like menopause, reaching menopause. Right? Could you please repeat the last part after medical management of endometriosis? Yes. After medical management is applicable for endometriosis if there are no fertility issues. That is clear because of these drugs. Okay, if a patient is in fertility wishes or fertility desire, you have to go for a surgical management. Surgically, not the THPA, so other things like adhesiolysis. Laparoscopically, you go inside and release the adhesions and release the block of the tubes. Then she can conceive. Okay, adhesiolysis. And if there are chocolate cysts, you have to remove them. Okay, mass system, mass, when I have chocolate cysts, you must have to remove them. 8 namas, candles, maybe the inside. Okay, that is the surgical management. Is that clear, Darwani? All right. Then we'll go into this, what is called DUB, dysfunctional uterine bleeding. Dysfunctional uterine bleeding. Any other name for dysfunctional uterine bleeding, Darwani? DUB term also they say now it's a bit outdated, so they have yes, AUB, abnormal uterine bleeding. So So please read the question carefully in the exam, Daruo, what they are questioning. Okay, whether they are asking about the heavy menstrual bleeding. Heavy menstrual bleeding means what? What shall we do? Adenomyosis with fertility issues. Outcome is extremely poor. Adenomyosis with the fertility issues, right? Normally, people with adenomyosis, they are family completed. But if a patient is having adenomyosis and fertility issues, again, you can't treat the adenomyosis. Why? Medically, if you treat, they can't have children. Surgical, only thing is hysterectomy. That cannot be done. So you forget about the endometriosis, adenomyosis part and treat the patient's fertility. Like if a patient is having an ovulation, you can ovulate the patient. Likewise, you can treat, but the outcome is not good. Adenomyosis and subfertility. It's very poor. Okay, Darwani. Take a deep breath. Think something interesting, very interesting thing that you are going to have tonight. You can have a dream about your future exam. It's very interesting, isn't it? Right? Okay, right. Come to the next part. Do you all feel sleepy? Can I take about 15 minutes from your valuable time? Is that okay? Right. Thank you. Right. Oh, right. Okay. Okay, Daroni, right. DUB, dysfunctional uterine bleeding. Or else, the exam they say AUB, abnormal uterine bleeding, same condition. What is this? See the name. This is more informative. I don't know why they have changed the name. Dysfunctional. Anatomically, there is no problem. So basically, even though you do 1,000 examinations and 1,000 investigations, you can't find anything abnormal on the genital tract. It's normal. But patient is having abnormal bleeding. That is purely because of some functional disarrangement of the endometrium. That is called dysfunctional uterine bleeding. So you get commonly this condition at the extremes of reproductive age. That is soon after menarche and towards menopause because of the hormonal imbalances. Okay. Suppose they will give a history like, there's a patient who is 45 years old, having irregular bleeding or having menorrhagia, and ultrasound scan unremarkable, no problem. Okay, likewise, they will give some scenarios, giving you hints that there is no problem. However, patient is having bleeding, abnormal bleeding. So what is your diagnosis, Darul? Dysfunctional uterine bleeding. Remember, to come to this diagnosis of dysfunctional uterine bleeding, you must exclude all other organic pathologies. That means you have to exclude adenomyosis, you have to exclude endometriosis, PID, or fibroids, and all these problems you have to exclude. Then only you can come to the diagnosis of DUB. Suppose now this is confirmed DUB. What are the management options then? Again, DUB also, you can have medical management options and surgical management options. What are the medical management options? Again, same thing, same thing, same things. You can use OCP, you can use Danazol, you can use, what else you can do? All those drugs, right? You can use Danazol, DMPA, OCP, Ulipristal, anything that we have mentioned so far, GnRH analogs, anything you can do. Okay. Surgically, what are the surgical options? What are the surgical options for DUB? Patient is having abnormal bleeding, but we can't. One more medical options for DUB. Another option is you can use tranexamic acid and mefenamic acid. Tranexamic acid and mefenamic acid. In menorrhagia also, I forgot to mention, you can give tranexamic and mefenamic acid during bleeding episodes. What is tranexamic acid, Pulastri? Tranexamic acid will stabilize
antifibrinolytic.
Yes, it stabilizes the blood clot. What is mefenamic acid? It's an NSAID, non-steroidal anti-inflammatory drug. It reduces prostaglandin production, because prostaglandin is the one which causes bleeding. So in menorrhagia and DUB, both you can give tranexamic and bifenamic acid. Okay, right. Then those are the medical management options. Surgically, last option is what, Taro? Last option is hysterectomy. In DNC, it's a diagnostic procedure. It's not a therapeutic procedure. If you want to get a biopsy from here, you have to do a DNC. Okay, Harshi? You have to do a DNC. If you want to get a biopsy, that's for the diagnostic purpose. I know that you all are tired. Just give me 5 minutes, right? So it's not a management option. Right. Come to DUB. So when it comes to the DUB, Daru, last option is hysterectomy. Before that, you can do what is called endometrial ablation. Ablation means you go inside and with the diathermy apparatus, you can burn out the endometrium. When you burn the endometrium, Taru, when you burn the endometrium, ultimately it will convert into what syndrome? What syndrome? When you burn the endometrium, what is a syndrome? Asherman syndrome. Yes. You induce Asherman syndrome. So afterwards, because of the fibroids, you won't get the bleeding. So DUB, one of the other option is before hysterectomy, if the patient says, so one of the option is you can go for endometrial ablation. Right? So endometrial ablation, right? And then if that is fails, hysterectomy. One more thing about endometrial ablation. Remember, this has been asked several times and we have discussed also. If you are going for an endometrial ablation, you must exclude a cancer or precancerous lesion. Suppose if there is endometrial hyperplasia, you can't do ablation. Definitely, if there is endometrial cancer, you can't do it. Endometrial hyperplasia also, if it is there, you can't do the ablation. Why? Can somebody give me the answer? Why you can't do that? Coffee එකක් දෙනවා. Coffee එකක් හදලා මෙනේ ඉඳන් ගෙවනවා. කුඩිය කරලා ලෙවනවා. Right? So why you can't do endometrial ablation?
Then you can't biopsy the endometrium.
Adaru?
Then you cannot biopsy the endometrium if you ablate the endometrium. There could be a concurrent malignancy growing.
Halfway correct. Not the real thing.
Causes the
The thing is this.
Thickness of that endometrium will be increases, so that is why this hyperplasia, because the cell production is over, may growth more. So endometrium thickness also will.
Yes. You are somewhere there. You are somewhere there. One of the reasons is, there are two reasons, sir. One of the reasons is, if a patient is having endometrial hyperplasia with atypia, when you do the biopsy says endometrial hyperplasia with atypia. However, there is about 50% chance you may be having a hidden cancer somewhere that you have missed with your diagnosis. So when a patient is having endometrial hyperplasia with atypia, 50% chance there can be not only the hyperplasia, there can be cancer somewhere in the endometrium that you have not seen or you have missed. So if you just do the ablation, then you may be under-treating this cancer. Okay, that is one reason. That is one of the main reasons why you are not doing endometrial ablation if you are suspecting endometrial hyperplasia. Other reason is, Daru, as he mentioned, when you have endometrial hyperplasia, this thickness is very high. Endometrium is very thick. So when you do the ablation, you may remove the endometrium halfway, but the remaining parts, which is just underneath, can regrow. And you know, endometrial hyperplasia can turn out into cancer later. So because of those two reasons, endometrial ablation is contraindicated if you suspect endometrial hyperplasia or cancer. This is one of the questions given frequently and asking frequently about this fact. Okay, please remember about those things. Otherwise, if once you exclude endometrial cancer, then of course you can do endometrial ablation. is one of the good treatment option if you want to leave the uterus, preserve the uterus. Is that clear, Daru? Right? Is that clear? Yes. So another one more point regarding the management of endometriosis and dysfunctional uterine. If a patient is having kind of an irregular bleeding, irregular bleeding, definitely you must exclude a cancer. That's why we do DNC or a PIPL or a hysteroscopy. But menorrhagia, you don't want to do the endometrial biopsy. Why? Another frequently asked question. If a patient, if they give a history of heavy menstrual bleeding or menorrhagia, they are asking what are the possible investigations you are going to do. Will you do endometrial biopsy? Why you want to do endometrial biopsy? To exclude a cancer. Does cancer causes menorrhagia? No. If you have endometrial cancer, it causes irregular bleeding or a post-menopausal bleeding. It doesn't cause menorrhagia. So in a patient with menorrhagia, and in a patient with menorrhagia, you don't need to do endometrial biopsy. Okay. However, if a patient is an abnormal bleeding or an irregular bleeding, you have to do biopsy. One more thing before I leave this part, Daru. Suppose a patient comes to you, say 40 years old lady. Suppose I'm a female, 40 years old female. Okay. So I'm coming to your clinic and tell you, doctor, so about 5 months ago, I had my periods quite regular. Every month I had normal amount of bleeding. Okay. Then doctor, over last 5 months, my bleeding pattern is so erratic, so irregular. So I can't predict things. When I go to work, all of a sudden there's bleeding. So I'm so embarrassed, doctor. And most of the days I'm losing my duty also. So irregular bleeding for 5 months. What are the possibilities? Is a cancer is a possibility? Irregular bleeding? Yes, definitely yes. If anyone coming with endometrial, irregular bleeding, one of the thing is there is a possibility of cancer. So you have to do an ultrasound scan, and also to exclude the cancer, you have to get a biopsy. How you can get a biopsy? If your mother comes, how you will get the biopsy? Non-invasive way. You can just put a PIPL and take a biopsy. No pain, no need of anesthesia. It's a simple process. If your mother-in-law comes, invasive procedures, something like DNC. Take her to the theater and anesthesia, straight to the uterus, take a biopsy. Or do a hysteroscopy, invasive. Have a look and take a biopsy. Whatever the way, Daru, you have to do a biopsy. Normally, what we do is the PIPL. Okay, you do a PIPL. And PIPL says there is no cancer. Now you are, to a great extent, you are sure. Okay, patient is having bleeding, and currently also patient is having bleeding. To stop this acute bleeding, what are the drugs that you can give? I'm not asking about the long-term plan for this patient. I'm asking, now she's saying, doctor, over last 3 weeks, I'm having bleeding, clots, and she's looking pale. Yes, one of the things is you can start tranexamic acid. Sometimes it's alone may be effective. What is the other option? Yes, they'll give. Anisha. So other option is that you have to start noethistron, progesterone. Noethistron. Because why do they get the bleeding, irregular bleeding? Because endometrium is not strong, not sustainable. So this endometrium you have to maintain within the secretory phase. If you maintain the endometrium within the secretory phase, there is no bleeding. So to maintain the endometrium in the secretory phase, you give progesterone, noethistron. So to control bleeding of any woman having abnormal bleeding, to control bleeding, you can give noethistron. How long you will give? How long you will give noethistron? Just 1 or 2 days? 5 days? If you give 5 days, what will happen? For 5 days, she will not having bleeding. But once you stop the northeastern after 5 days, she will have another breakthrough bleeding, withdrawal bleeding. So if you are giving northeastern, this is one of the common mistakes done by the GPs, right? So if for abnormal bleeding patient, if you are giving northeastern, at least give at least 21 days, or at least 14 days, better 21 days, 3 weeks. Give northeastern continuously 3 weeks. Then during that time, endometrium will be stabilized and secretory phase. Then once you withdraw it, they will not be heavy bleeding. Okay. So what I want to tell you is, if a patient is having irregular bleeding, remember irregular bleeding, not menorrhagia. I'm talking about irregular bleeding. If a patient is having irregular bleeding, irregular bleeding, not menorrhagia, you exclude the cancer. If there is no cancer, you can start tranexamic acid and northeastern together and give northeastern at least for 3 weeks. I know now it's very difficult. I know that. I know that, right? Just so after 21 days, she will have bleeding. Yes, after 21 days, when you stop northeastern, definitely she will have bleeding, but that bleeding is not that heavy like the bleeding she had before. She will have like a menstrual bleeding, 2-3 days bleeding, and after that it will stop. Okay, that one. Okay, right. So now it's 11:15. You know what is that, Nusrat? No? Right? Okay, right? So far what we have discussed, Darwani, right? I gave a brief introduction about the menstrual cycle, the physiological part, right? Then we discussed about amenorrhea and what is this hypogonadotrophic hypogonadism, hypogonadotrophic and hypergonadotrophic and ovulation. What are these terms means? Okay, Darwani. Then we discuss what is menorrhagia, what are the causes, and how to differentiate, how to shortlist your differential diagnosis. What are the salient features of adenomyosis, endometriosis, and all, right? And the management we have discussed, like medical surgical management. Okay. Then we have discussed dysfunctional uterine bleeding or abnormal uterine bleeding, right? Abnormal uterine bleeding also, to come to that diagnosis, to come to that diagnosis, you must exclude other things before you come to the diagnosis. The management, of course, you have medical management options, and surgically, you have a good option, that is what is called endometrial ablation. But make sure before the endometrial ablation, there is no cancer or endometrial fibrosis. Okay. So if you all are okay, I can recap the anatomy part also in about 10-15 minutes. If you are tired, we can stop it now. What do you think? Right? So if you are tired, okay, we'll do it, right? I will take maximum about 10 minutes there, okay? Just to recap, because I know that otherwise you don't have time to recap on your own. I hope this part would have been important for you all. Right. Now forget about the menstrual cycle. We'll come to the basic anatomy that they are going to ask in your exam regarding the genital tract. Okay. Right. So we will first discuss about the arterial supply to the pelvis. This is the abdominal aorta. Abdominal aorta divided into two common iliac vessels. Two common iliac vessels. This is one of the common iliac vessels. Again, divided into external iliac and internal iliac arteries. External iliac will be directly going into the lower limb, whereas internal iliac is the one which supplies the pelvis. Internal iliac also, after the forming internal iliac, divide into anterior division and posterior division. Posterior division will supply the most vital organ in your body. What is the most vital organ in your body? Gluteus maximus, right? So these buttock muscles will be supplied by the posterior division, whereas anterior division is the one which supplies the pelvis. So when you take the pelvis, you have the uterus, vagina, right? Bladder, rectum. So it's very easy to remember. This is one of the common MCQ, right? So this is the aorta, abdominal aorta, divided into common iliac. Common iliac divided into HP, internal iliac and external. Shall we all of us take a deep breath? Take a deep breath. Relax yourself. Only 5 minutes. Only 5 minutes. Okay. Hang on. So abdominal aorta divided into common iliac. Common iliac divided into internal iliac and external iliac. We don't talk about the external iliac. The surgical people will talk about it. Right? Internal iliac again divided into anterior division and posterior division. Anterior division is the one which supplies all pelvic organs. You have to remember by heart these 5 branches. It's very easy. So one of the branch will be going into the uterus. What is that called? Uterine artery. Another branch will be going into the vagina. That is called vaginal artery. Another branch will be going into the bladder. That is called superior vesical artery. So vesicle means the bladder. Superior vesical arteries. Right? Another branch will be going into the rectum. Middle rectal artery. Another branch will be coming to the perineum. That is the vulva, the outside perineum. That is called pudendal artery. Internal pudendal. So 5 branches, Daru. Internal iliac artery has 5 branches. What are those 5 branches? Uterine artery, vaginal artery, vesical arteries, right? Middle rectal artery and internal pudendal artery. This is a common MCQ. Usually, a paper MCQ first or the second question, they give an anatomy question, right? So this is one of the questions, right? 5 branches. Very easy to remember. Uterine, vaginal, rectal. Rectal, middle rectal, right? Superior vesical, internal pudendal. 5 branches. So common iliac artery, internal iliac, anterior division of internal iliac. Right. What about venous drainage? When it comes to venous drainage, Daru, there are no single veins as such, but venous plexuses. So you have uterine venous plexus, bladder venous plexus, rectal plexus, like that venous plexus. They all join together and they drain into internal iliac vein. Right? They drain into the internal iliac veins. So from here, from there, like that, venous plexuses, in venous plexuses, they all join into internal iliac vein. Internal iliac vein join with the external iliac vein and form the common iliac vein. 2 common iliac veins on either side will form the aorta. They will form the inferior vena cava and they will drain into the heart. So venous plexuses drain into internal iliac vein. Internal iliac vein combined with external iliac vein form the common iliac vein, drain into inferior vena cava. Okay. And there is a difference when it comes to the ovary. Ovary, Daru, arterial supply also. When it comes to ovary, arterial supply to the ovary also coming directly from the abdominal aorta. Arterial supply to the ovary is not from the internal iliac vessels. It is direct. This MCQ is directly coming from the abdominal aorta. Same like the testis. Testis and ovary and Aya and Nangi. Or Chutimali and Nangi, something like that, right? Testis and ovary, right? So both of them get the blood supply directly from the abdominal aorta, not from the internal iliac vessels. MCQ. When it comes to the venous drainage, what about the venous drainage? So this is the inferior vena cava. Inferior vena cava here. You have the renal veins. Renal veins. These are the kidneys. Okay. So So you have the ovaries on both sides. Right side ovary drain directly into the inferior vena cava, whereas left side ovary drain into the left renal vein. So the test is also the same. Can you all remember? Test is left testicular vein drain into the left renal vein. Ovary also the same. Left side drain into the left renal vein. Right side drain into the inferior vena cava. In males, why varicoceles are more common on left side? This is the reason. Females, there are no, we don't talk about varicoceles, right? But the venous drainage is the same. Please remember those differences, because those are the key points that they will you will be questioned. Okay, so please remember what is difference in the venous drainage. Is that clear, Daru? What about the lymphatic drainage? Lymphatic drainage. So you have the uterus here, cervix there, tubes are there, and you have the ovary on either side. So lymphatic drainage. This has not been questioned recently. Okay, so you have to expect this one in your paper this time. So this is the abdominal aorta on the back side, divided into common iliac like that. Okay, so fundal lymphatics from the fundus, this area, drain into aortic lymph nodes, like para-aortic on either side, para-aortic lymph nodes, fundal lymphatics. From the body of the uterus, they drain into the external iliac lymph nodes. External iliac. From the cervical region, very important, cervical cancers, cervical region, lymphatics drain into external iliac. Okay. Clear? So from the fundus, they drain into, this is the uterine lymphatics. Okay. From the fundus, they drain into para-aortic lymph nodes. From the ovaries, also the same. They drain into para-aortic lymph nodes. From the ovary and fundus of the uterus, they drain into para-aortic nodes. Okay. And body of the uterus, external iliac, cervix, external, internal, and sacral lymph nodes. The last point before I stop. Remember, this is another MCQ. Some of the lymphatics from the fundus, especially this cornual region, some of the lymphatics here, closer to the cornua, on the fundus, they drain into superficial inguinal lymph nodes on the groin area. Superficial inguinal. What does that mean, Saru? When you do the clinical examination, when you come to the, after your MCQs and all, when you come to your the Viva, right, clinical cases, you have to examine the superficial inguinal lymph nodes. Why? Because some of the uterine cancer can drain into superficial inguinal nodes, especially closer to the cornual area. They drain into superficial inguinal lymph nodes. Is that clear, Daru? So lymphatics wise, fundus and the ovary para-aortic lymph nodes, and some of the fundal lymph nodes will drain the superficial inguinal nodes on the skin, and from the body external iliac, from the cervix, external, internal, and sacral lymph nodes. Okay, right. So this is not a full theory part for these topics, right? This is kind of a nutshell. This is kind of a summary. There are a lot of mosquitoes. This is kind of a summary for you all to recap your theory part quickly. That I think this would have been helpful for you all. Just give me a comment if you think that this needs to be done, right? So if you are happy, I can do 1 or 2 more. I can take some difficult topics, so-called difficult topics, and we can discuss like this way. And that will be, I think, important for you all. Okay. Yes. Thank you very much. And thank you very much for joining today. And have a sleep now and study tomorrow. Okay. Thanks a lot and good night.
Sir, excuse me, sir.
Yes, sir. Yes, sure. Go ahead.
Sir, that Amenorrhoea syndrome, sir. The one
Yes.
without the uterus.
Yes.
That also can we consider primary amenorrhoea, but anatomical path is only abnormal, but this HPO axis is normal, like similar to this, what do you call that, septum and imperforate hymen.
Yes, exactly. Yes. So in Amenorrhoea syndrome, or Mullerian disease, they are females. They have ovaries, functioning ovaries, so they have proper secondary sexual characteristics like girls, normal way. However, they don't have a uterus and the cervix, so they will be primary amenorrhoea. Externally also they are like females, internally also females, but absent uterus. Only thing is absent uterus. They have ovaries, so they will be primary amenorrhoea having secondary sexual characteristics. In people with imperforated hymen or the transverse vaginal septum, also the same. They have ovaries, they have secondary sexual characteristic, but they are primary amenorrhoea. The difference is they will have cyclical abdominal pain because they have a uterus inside. So they have bleeding, but the bleeding cannot come out. So since the blood getting accumulated inside, they will get cyclical cramped abdominal pain. That is the differentiating factor from Mullerian agenesis and these transverse vaginal symptoms or imperforated. Okay, right?
Thank you, sir.
Okay, cheers. Right, Daruni. So if you all have any questions, please send me through the WhatsApp or whatever the way. I will. I'm happy to answer them and clarify those doubts. Okay. So have a good sleep, Daruni, and we'll meet up soon. All right.